A very warm good morning to all the conveners, judges, and fellow participants present here. Today we are going to discuss about visual evoked potential and assessment of optic nerve toxicity in ethambutol therapy in tuberculosis. I will be the presenting author here, and my co-authors were Professor Dr. Subhavita Parida ma'am and Assistant Professor Dr. Anita Misra ma'am from SC Medical College. I have to say that there is no financial interest involved. Introducing to the topic, tuberculosis is an imminent threat in developing countries, including India, with the causative organism being Mycobacterium tuberculosis, which is slow-growing acid-fast bacilli. The first line of treatment consists of isoniazid, rifampicin, pyrazinamide, ethambutol, and sulfonamide, out of which ethambutol is given as ethambutol hydrochloride, which is a bacteriostatic agent with FDA category 3 clearance. Side effects of ethambutol hydrochloride includes headache, loss of appetite, nausea, fever, hyperuricemia, and visual toxicity seen in 1 to 5% of cases. The ocular toxicity with ethambutol can be attributed to optical neuritis, with the chief complaints of such patients presenting with color vision deficiency, loss of visual acuity, visual field loss, generally resulting in central scotoma, or can result in bitemporal myopia with contrast sensitivity loss. Increased toxicity is seen in patients with renal dysfunction. Early detection has shown to show better reversibility in symptoms. J.B. Green et al. And J.M. Guerin et al. In their different studies showed that somatosensory and auditory evoked potential can be used to detect the neurotoxic effects of aminoglycosides and phenytoin early on in the therapy. So on the same line, we can use the changes in the latency of visual evoked potential to study the toxicity of ethambutol here. So we decided to do a prospective study on patients getting antitubercular therapy and traced out patients who developed ocular defects during the intensive or continuation phase of the treatment with BP study and subsequent follow-up. 79 patients were selected, 48 males and 31 females of the age range of 18 to 50 years with recent diagnosis of tuberculosis and who were to be started on antitubercular therapy. Ethambutol dosage was kept at the prescribed dose of 15 to 19 milligram per deciliter. Patients with previous history of visual abnormalities and who could not be properly followed up were excluded from the study, and proper patient consent was taken before starting the study. The tests done at the start included visual acuity test using Snellen's chart, visual field test using Goldman's perimetry. The color vision was tested using HRS chart, contrast sensitivity using Peller-Robson's chart. Fundus examination was done using indirect ophthalmoscope, and pattern visual evoked potential, as shown on the right side of the slide, was done using electroencephalogram. 2 months into the therapy, all the above tests were repeated on monthly basis, followed by a single 6 months follow-up. Each of the 158 eyes were again subjected to monoocular BPs on monthly basis by an established procedure, and patients with increase in P100 latency tested for serum folate and vitamin B12 levels. The results showed that during the course of antitubercular therapy, the P100 latency was delayed in about a staggering case of 134 eyes, which accounted for 85% of the cases studied. Contrast changes could be observed in 24 eyes, about 55% of cases. Contrast sensitivity was detected in 5% cases. Only 1% presented with changes in visual acuity, visual field, and perception of column feature. The serum folate and vitamin B12 levels were found normals in all the cases tested. This is the tabulated format showing the mean value of the P100 latency, which showed subsequent increase with the study. The P100 latency delay, as can be seen in the graphical data, showed increase with each month's data with confidence interval and standard error coming into the p-value range. These are the VP changes recorded. In 134 eyes which increased P100 latency during ethambutol therapy, they were followed up 6 months after completion of antitubercular therapy. Out of them, P100 latency showed reversal in 72 eyes, which accounted for 53.7% of cases, as shown in the tabulated format here. This is the P100 graphical data representation showing delay, which was high during the 6 months therapy, and post 6 months ATT, they showed decrease. There has been seen a decrease in the P100 amplitude with the increase in P100 latency in majority of the patients. Now coming to the discussion part, KL Kim et al. Studies found out that visual field test, OCT, contrast sensitivity test, DEP, electroretinogram, and electroculograms are all effective diagnostic tools to detect clinical ethambutol-induced ocular toxicity. Now, according to this test of mine, toxic optic neuropathy can be detected by VP study, which is consistent with studies by S. Sokol et al. Although both amplitude and latency of P100 changes in the condition, but P100 amplitude shows subjective variation. So latency of P100 value is a better indicator, as has been observed in study by B.S. Oken et al. Now coming to the ethambutol toxicity, many authors postulate the underlying disturbances to be due to mitochondrial disturbances or zinc chelating effects and its metabolite. The end result is ethambutol shows a delay in the axonal transport as a result of both axonal swelling and myelin thinning. So in this study, we tried to emphasize on the role of timely and routinely done pattern VEP study to detect subclinical optic nerve changes in ethambutol therapy. To conclude, we believe that out of all the visual function tests used in this test, pattern VEP is highly suitable for early detection and prognostic follow-up in ethambutol-induced ocular toxicity. Also, it can be noted that majority of patients with ocular toxicity due to ethambutol therapy revert back to normal test functions 6 months after stopping ethambutol intake. These are all my references. Thank you.
Thank you, Dr. Partha. Since Satya has done work on this, Satya, would you like to take this?
Yes. So, Dr. Partha.
Yes, sir.
How many months follow-up do you have?
Sir, I did the study for a span of 12 months, means more than 15 months, out of which the first 6 months were for during the therapy, and post 6 months anti-tubercular therapy, one VEP study was done.
So how many times did you do VEP study?
Sir, VEP study was done, sir, for 7 times in a patient. During the therapy, at the start, one was done. Then after 2 months, monthly basis for 6 months, 5 were done. And then at the end, post 6 months of therapy, one was done.
So I must compliment you that it's a prospective study. That is a wonderful thing that you have done. Second, that you have utilized VEP because this is a very underutilized piece of equipment which is lying around in huge number of hospitals and not being used.
Yes, sir.
Third is, I would like to know, you said fundus findings. What were those 24 cases fundus findings?
Sir, the fundus findings were varying from patient to patient. In most of the cases, out of the 50% cases, that showed hyperemic disc changes. And there was slightly margin blurring, morely to the lateral aspect of the disc. That type of changes, sir. There were no significant visual changes in those patients.
There were no visual acuity changes in those patients?
Only one patient, sir, showed visual acuity change. The rest of the patients had no such significant visual acuity change, sir.
So the fundus finding was compared with that at baseline?
Yes, sir. Sir, in the baseline, we took all the patients who had normalized and normal fundus finding with visual acuity of 6/9 or better.
Yeah, correct. But did you have fundus photos at baseline? And then when you found those 24 eyes with hyperemic disc, you compared the fundus photos?
Yes, sir. Yes, sir. We compared the fundus photos during the course of the 6 months therapy with the baseline photo, and we found hyperemic disc in major, means the fundus changes that I have included hyperemic disc changes.
Was there any observer bias in this?
Sir, I don't think so, sir. This data has been verified by me and my co-guides also, co-authors also. So.
Okay, so now the next thing is that so disc hyperemia, and that's interesting.
Right. Yeah.
The thing is that VEP, and in a large number of cases you found delay in the pattern VEP, right?
Yes, sir. Yes, sir.
Okay, how does that compare? In how many percent of cases?
Sorry to interrupt, doctor, but the time is up.
Okay.
I understand. Let
Sir,
me continue.
Yes, sir. Sir, the pattern VEP can be used as a prognostic evaluator, so that we can use that value to follow up patients and to check for the visual acuity changes if there can be anything in the future, and to allow the patients to report to us as soon as possible as they see that if there is any visual acuity change.
All right. Thank you, Dr. Partha.
Thank you, doctor.